Hi, welcome everyone. Thank you so much for joining our virtual morning report. Good morning, good evening, good afternoon. I'm excited to be co-discussing with Ravi today. And I think first, let's introduce the people who are making this happen. It looks like using Ravi's word is an internal affair with our beloved presenter, Eugene. Congrats on your recent match. And Eugene, maybe you can maybe we'll leave you to introduce yourself last, but we can have Simi and Krishna say hi to us. Congrats to both of you as well.
Hello everyone, so excited for discussion by my favorites, Dr. Ravi and Dr. Mengyu, and very excited for the session. And thank you so much for all the support I have received from my CPS family. Very grateful for that as well. Looking forward to the session.
Hi everyone, I'm Krishna. I'm really excited to the case and to the discussion. I always enjoy doing teaching points for any VMR.
Yeah, and maybe we'll pass the mic to Eugene.
Yeah, hello everybody. I'm Eugene, medical officer from Ghana. Very excited to bring this case that I saw about 2 months ago, and also excited to be presenting it to Dr. Ravi, Dr. Mendy, very wonderful mentors to me. I've been part of my journey so far, and then also my match success. So very excited to present to them.
Yeah, it's not the first time Eugene is presenting to us, and I still remember the last case. Some stumped me, but it was a very rich, good learning. Always remember that case, like just under 11. Um, but yeah, I look forward to your another case from you. I'm sure it's a great learning. And Ravi, may pass the mic to you to maybe get us started. And
Oh, sure. Yeah. Hi. Welcome, everybody. Tuesday afternoon VMR. I usually do this in the early afternoon. But day is winding down, so nothing better than to discuss a case with my great friend Mengyu. Absolutely wonderful to be on with Mengyu today. And Krishna, Krishna's going to do teaching points. You want to unmute and just say hi?
Hi everyone. I'm Krishna. I'm an international medical graduate. I'm going to be doing teaching points today. I'm really excited to the case and the discussion.
Okay. Well, let's start with the first aliquot. Eugene, you want to take it away?
Yeah,
And
just for the white, but
Mengyu can tackle the first aliquot.
sure.
okay, so the first aliquot, I mean, it's divided into six, seven aliquots. The first aliquot, I will share an image, then we'll take it from there. Oh, yeah, see me sharing. So, the 36-year-old female with 3 months of easy fatigue, joint pains, and 1 month of evolving skin rash. And that's the skin rash.
Oh, wow. What a remarkable start. And sorry, I missed the first sentence you said, Eugene. What's the age again?
36-year-old female.
36-year-old female. Got it. So it's pretty young lady. 1 month of this um, rash and also accompanied by fatigue and joint pain. So almost reminds me of our last case where we have like a, joint pain as a start, but as what sounds like a systemic symptom going on. So maybe I'll start talking about the rash. So we know it's in the background of the subacute course. Um, uh, rash is not my strong suit, so I'm gonna to just try. Uh, Always like when we see a rash, think about whether it's a primary dermatologic issue, which like is in practice like 90% of the case, versus like a tip of the iceberg. I think using Ravi's words, like, but basically, is it an outside job, starting from the skin, a local derm issue, or is that like an inside job uh, having a systemic nature? And we can even glean from the time the systemic like joint pain and fatigue to think of it as probably a systemic issue. Um, so, uh, I think then what comes next is the nature of this rash. A rash can transform, as we learned from Kirtan. It can start as anything as a non-specific, but then evolve into either like purpura or vesicular or vascular, so or ulcerative. So usually as they evolve, we get more clues, are able to narrow down our differential. So just by looking at the skin, I also notice this is you know a black patient, so that often can actually make the interpretation more challenging if we only work in a population where it's Caucasian, where so I think just to be mindful about kind of this this diverse patients that we take care of. So what I'm seeing, trying to get really closer is some nodules maybe, but also it's a little hard to say. Maybe some scaly rash, but also like the distribution is interesting in that involves the bottom of the feet, so the palms, and so here is the soles of the feet, and we know like rashes that involve the soles are palms and soles are not that like there's some unique uh, things like infections, certain type of infections like virus, and certain type of autoimmune diseases. So um, some, it's like the differential is still pretty broad. Um, Syphilis is like a classic that we always have to rule out among the infections. But I think otherwise autoimmune, like if you just think of along the line of IMAID, it's still pretty broad. From an autoimmune paraneoplastic to like medications or other, or even like nutritional deficiencies. Yeah, so I'm not entirely clear yet. I would need help from Ravi and others, how we can make progress from this rash. Yeah, I'm going to pause and see what thoughts Ravi has.
Oh, thank you. No, you just did a wonderful sort of overview of what is going on. And yeah, I was amazed. I looked at the pictures and I was like, wow, this rash is quite prominent and is on the soles. And you mentioned syphilis, and you know what I was thinking while you were mentioning or describing the features? I was like, how so we have a young person, so young people tend to have unusual manifestations. And then I was looking at tissue and the journey of this tissue, which is skin, and then joints are involved. The other thing Eugene mentioned was fatigue, and the fatigue I'm not really concerned with because the amount of inflammation likely that is going on with this patient is possibly feeling the fatigue. So if you move away from fatigue and just think about joint and skin, and there are a couple of very classic medical conditions where you can develop um, um, pathology in both the skin and the joint. One could be, you mentioned, if we think about classic immunological conditions, immune complex deposition can result in this. So any sort of things like vasculitis, connective tissue disease, certain infections could cause this. The other thing is a lot of these tissues are shared embryologically, right? And you have certain like cartilage, capsule, synovium, dermis, and there's a lot of mesenchyme within a lot of this connective tissue that you have. So in autoimmune phenomena, each ones are fair game. Each one of these different tissues are fair game. The other thing is you mentioned then the bucket of infection, sorry. An infection can feel this inflammation. So all sorts of different infections, whether it be Neisseria, chlamydia, syphilis, any one of these could actually be disseminated by the bloodstream and then cause this diffuse inflammation that we're seeing. Um, is there anything else I can think of? The other thing is endocarditis via the bloodstream could cause this. But at this juncture, I'm not sure. I need more data to see, is this an internal condition? Internal would be the whole, I get the whole these conditions of connective tissue diseases, autoimmune phenomena, so on, or is this an external condition like an invader, like infection, like maybe putting maybe something topical on the skin and causing this reaction. Um, Other internal conditions could be, or angioedema, things of that nature. Um, but I kind of would start with this and look for any past medical history. This could be the first manifestation of autoimmune phenomena, but infection is still fair game in this sort of presentation. All right, I kind of rambled on a bit, but you get what I'm saying, what I'm mentioning, right? Um, any other thoughts, Mengyu, before we turn the mic over to Eugene?
No, I would also rely on Eugene's expertise in terms of describing the rash, like how it feels, and maybe clarifying more associated symptoms like pain or itchiness or thing. Yeah, so I'm sure we'll learn more from Eugene to help us make progress.
Yeah, fantastic discussion. So she was apparently well until about 3 months, and she started having this fatigue, reduced exercise tolerance, and also was followed by joint pains. It involved both small joints, so in the fingers, then in the elbow joints, knee joints, ankle joints. But then there was no swelling, no more stiffness. She also started having numbness, reduced sensation in her lower limbs. And then she's noticed the rash. That was 1 month ago. It was progressive. It was not itchy. It was not painful. There were no ulcerations. She also reported intermittent retrosternal chest discomfort. It was worse when lying flat, relieved, or sitting up. It was associated with palpitations occasionally, but not when she was exerting herself. There was no autopnea, no parasitoma, maternal dyspnea, no syncope, no cough, no hemoptysis. Fever was sometimes subjective at night, but most of the time she was not febrile. She didn't have any weight loss, no rigors. She didn't report any recent infections in the throat or urine. No night sweats. Also, no history of headache, visual disturbances, no focal weakness, no bowel or bladder dysfunctions. The rest of the stomach review was normal. Gynecological history, she had regular menstrual cycle, no menorrhagia. There was no history of miscarriages, stillbirths. She wasn't on any hormonal contraceptions. In the past medical history, she had no known history of hypertension, diabetes mellitus, but no significant past medical history, no significant family history. Also, for social history, she didn't have any significant alcohol usage or smoking or any use of illicit substance. Before she came to us, she had attended a peripheral hospital with the complaints of the chest discomfort, where she had an ECG done. The ECG was suggestive of a possible inferior wall ischemia. That was the report that was given from the peripheral side. And we did an echocardiogram, which showed normal left ventricular systolic function, normal ejection fraction, but there was evidence of grade 1 diastolic dysfunction, no valvular or pericardial abnormalities. We'll say that when she came, we reviewed that ECG, which we thought that it was just T-wave changes in these two or AVN with sinus bacteria. And we'll stop here and allow you to discuss.
Oh wow, Eugene, this case is becoming very interesting, and you've added another layer. We have the joint pain, the fatigue, and then rash. And I think the answer lies in what's driving the rash. But when you have rash, joint pain, now nerves involved, as this person is having peripheral numbness and coldness and burning, you start to think about certain conditions. So when you start looking for conditions that can affect all these different tissues, you can't help but think of vasculitis is a certain condition where something like this comes to mind. Usually with peripheral neuropathy, which starts in the legs, usually if you think sensory over motor, you haven't mentioned any weakness, but this usually will be something along the axonal lines. The most common cause of this would be diabetes, alcohol use disorder. These kind of conditions would explain this. And you usually will have this kind of stocking glove distribution with something like this. I think with alcohol, you tend to have a lot of burning as well, which is mentioned as though your lower extremities are on fire. Right now, we haven't gone into behavioral history, so we can't really delve into alcohol use disorder as a cause. But I think when you have nervous dysfunction, what kind of conditions will cause this? Is it the blood supply to the nerves, the vasa vasorum, and so on? Is there also immune complex deposition affecting the nerves? This is not likely demyelination, which is usually the other cause of nerve dysfunction, where you would have motor more than sensory. So initially, motor dysfunction, which would be peripheral as well. So I'm still in the domain of autoimmune phenomena. Infections are still fair game with this. Occasional night sweats, this usually has an association with certain malignancies. Could a malignancy with a paraneoplastic manifestation be able to explain this? It could be possible as well. But I'll turn the mic over to Mengyu to see where this aliquot takes her.
Yeah, thank you, Eugene. This is such a rich aliquot. I feel like a lot of every piece of information in this aliquot we can try to take as much as juice from. So, this first we have the signal of poly articular involvement, so including small joints. So we can kind of frame it as a polyarticular arthritis, and for that, really. The most common differentials are viral if it's more acute, but 3 months, makes the viral etiology less likely. So I think autoimmune kind of looms large. And with that in mind, we then hear there's a neuropathy. So is it a typical or atypical neuropathy? So a typical neuropathy would be featured by 3S, so like symmetric, sensory, predominant, and slowly progressive. And usually it's an axonal distribution, like length dependent, would involve palms and soles, as you see commonly in diabetes. So here it sounds like, although it's not specifically location described, but sounds like it involves both feet and legs. So I'd be curious if it's more of a atypical neuropathy that kind of involves even towards the legs, but mostly it does sounds like a sensory predominant. We don't hear any motor involvement. So I mean, I guess it could still potentially be a axonal, but then I think the progression is really faster than a normal axonal neuropathy. So I think we should call it like an atypical neuropathy. And for that, we always want to rule out like ABCD. The A is like in AIDP or even like AIP if there's any other autonomic features like what I mean is like acute intermittent porphyria, but I don't think I get other signals yet for that. But then I think autoimmune is a big category for the A as well, like vasculitis, as Ravi mentioned. But it's hard to diagnose. We kind of also want to rule out other things. And for B, we can think about the vitamins deficiency. So I think routinely we can do send like B12. There are other vitamins we can also consider like B1, 3, or 6. So if excessive or deficiency in vitamins, another possibility. And then C, like we want to make sure it's not like cauda equina, or like a spinal cord compression type of picture, which we learned from Jeffrey's, one of an internal case that kind of mimic this. But I think that seems to be less like given that it involves both feet. Yeah. I don't think we're dealing with botulism here. There's no bulbar weakness or any weakness even. And then heavy metal toxicity is another possibility. Um, However, I think once we then consider another feature, the what sounds like a pericarditis, because of positional chest pain, worse with lying flat, really makes me think there's an underlying pericardial inflammation, and that really points towards like autoimmune systemic autoimmune disease like lupus, um, which could potentially unify other findings, especially the joint pain and certain sensory like neuropathies. Uh, I think then we kind of want to connect how the EKG is related to the chest pain here. I'm curious about the T wave changes in because like if you just think about 2 and AVF, and sometimes you can correlate because 2 and AVS are all inferior leads. Also, we can see if there's any lead 3 changes. I remember there's a but in if there's a truly pericarditis, you don't see it in all EKGs, but sometimes you can see ST elevations and PR depressions. Um, T sounds a little bit T wave changes sounds this sounds like a little bit more non-specific at this time, but I'd be curious to see if there's any other clues. I think even though the echo didn't mention about a pericardial effusion, so that might make it a little less likely, but I think that doesn't rule it out. So I think that's still on my mind. We're getting inflammatory markers. Like I think if to diagnose pericarditis, you need the classic symptoms, which this patient has, plus one of the following, like inflammatory markers or echo findings of pericardial effusion or EKG changes, or I think there's something else. But yeah, so far I think it needs a little more understanding whether this could be pericarditis. Um, yeah, so I think maybe let's look at the exam and lab to see if there's other clues of a systemic autoimmune disease. For example, if there's cytopenias or things like that, or more organ or kidney involvement that could definitely point towards a lupus, and this patient is kind of in the right age and gender for that. Yeah, I haven't really talked too much about the rash though. I wonder if Ravi, you have other thoughts since that is the initial presentation.
Yeah, I think that was a great breakdown. This now you brought this chest pain in, and you raised a really important question. This could possibly be a serositis, and lupus is front and center in this kind of presentation. And with the small joints of the hands, yeah, I just wonder, is this arthralgias or really is arthritis? The small joints of the hands usually typically associated with rheumatoid, but sometimes you can have a lupus and rheumatoid, this lupus overlap, where you can get destructive involvement of the articular surface. So yeah, the exam will be very helpful in this case. The skin condition in itself, I mean, looks quite confluent, symmetrical. At this point, yeah, I don't know. I think lupus can manifest with this too. I think also somebody was mentioning, could this be erythema nodosum? I don't think this because it's involving the soles as well. I think likely, I mean, lupus, and then some of the infectious conditions we talked about with syphilis. You can also have Coxsackie can cause in this case as well. And Rocky Mountain spotted fever is another one, if I remember. Yeah, at this point, I think an exam will be helpful to kind of discern which way to go. But I think we will need a solid panel of lab testing, especially getting an ANA will be very helpful, and then looking at the white cell count and the nuances, the breakdown to see which way to point out diagnostic compass. Back to you, Eugene.
Yeah, thank you so much. This is those are quite amazing thoughts, and I'll give you the examination findings. I'll start with vitals. The temperature was 36.8. Pulse rate was 108. Was regular. The blood pressure was 118/72. Respiratory rate was 13 cycles per minute, and she was saturated at 98% anemia. Just looking at her generally, she appeared chronically ill. She was not in respiratory distress. She appeared pale. There were no lymph nodes that were palpable at the peripheral sites. On the skin, we saw this mottling pattern that we all saw in the picture. The lower limbs, they were non-blanching. We also saw some in the upper limbs and also the chest area. They were non-blanching, brownish, we call them peck-quick lesions. They were scattered, like I said, of the legs, arms, and then the chest area. Cardiovascular examination was normal. First and second heart sounds were there, no murmurs, no gallops, no pericardial GDP was not elevated. There was no peripheral edema in the lower limbs. For respiratory examination chest was clear. Abdominal examination revealed a soft, non-tender abdomen with no hepatosplenomegaly and no other organs palpable. The musculoskeletal examination, the pattern of tenderness of the joints was symmetrical, so both left and right were tender at the wrist, knees, ankles, and also in the digits. But we didn't see any swelling, no deformity, and no restriction of movement. The neurological exam was intact, reflexes were preserved, and the sensation was also intact. Then I'll give us just a few investigation in addition, and then I'll pause. So for complete blood count, hemoglobin was 6.1, MCV was 88, MCH was also normal, Y cell was 8.2, platelets was 203. We did cardiac troponins because of the chest discomfort was normal. We did a quick ECG. It shows sinus tachycardia, same non-specific T waves in the epidural leads, no ST changes. Yeah, and then we did ESR, which was high, 150. CRP was also high, 129. I'll pause there and then let you share things.
Oh, wow, Eugene. What a fascinating case. And the exam itself is so interesting. So maybe I'll dive into the exam and Ravi can add things that I missed and also kind of talk about the labs. Um, so yeah, we have a lipido reticularis. So thank you for your, this awesome description. I think it was hard to recognize first just by looking at the imaging, but now that reflecting on, I think it does make sense just looking at the imaging more closely. So yeah, that is a big clue, and we're dealing with non-blanching. Non-blanching basically means purpura, and I think even when you said there's no pain or other symptoms, I think I had wondered if it was could be a purpura, and I think you just pointed out that it is. So when we think about purpura, we can think about either due to bleeding or thrombosis. Bleeding is like when you see in like low, when there's like low platelet or INR or vascular integrity issues or bleeding, things like that. Usually it's non-palpable, and you can have like ecchymosis or things, but it sounds like that's not what we're dealing with here because the reticular pattern really points towards a vessel problem. So because the reticular is kind of basically suggesting the vessel, the shape of the vessel, almost I think at another extreme of this, if it keeps progressing, or sometimes you can form like a reticular retiform purpura. So yeah, so that reticular pattern. I think usually you mentioned that it is palpable, but even if you haven't mentioned, I would think this is a vascular issue, like a vascular thrombosis. So for that, it is usually like inflammatory blood vessel disease as one possibility. The other is like microthrombosis, or sometimes they can go together. Um, so vasculitis is like a big category. And you can think along the line of usually, I'll be curious to see, usually haven't told us any kidney involvement because they often go together because small vessels in the skin and small vessels in the kidney, if they involve together, that's we commonly see. So it can either be pulsing immune, uh, it's just like the vessel itself is inflamed, so like in ANCA vasculitis, so that is a possibility. Or there's immune complex depositing and causing that inflammation. So that you can then further divide into if the complement is involved. I mean, immune complex, usually you think the complement is involved, but like, for example, in IgA, the complement would be normal. So I think that's an important branching point next. But other conditions like cryo, or lupus, Sjogren RA, like a few systemic autoimmune diseases, and endocarditis, as Ravi mentioned earlier, is also important consideration. I think otherwise, if it's just limited to the skin, you can have this like condition called hypersensitivity, small cell vasculitis, or cutaneous small cell vasculitis. But yeah, but I don't think it's just like it seems like there's a systemic involvement. So I think big categories are cryo. A cryoglobulinemia often comes with nerve. So like the nerve changes, the neuropathies, you can think as part of the small vessel vasculitis. So this goes along with the vasculitis picture. Um, Same as ANCA. So I think ANCA, IgA, I think IgA is probably less associated with a neuropathy, so I would think that's less likely. So I think ANCA, cryoglobulinemia, lupus, including Sjogren, are all very, high on the differential. And endocarditis, I think it's 3 months is a little bit extended for that, unless there's some subacute. But I don't associate neuropathy a lot with endocarditis. So, and then I think Paris neoplastic can mimic, of course. And I think thinking along, then taking it further, like another category is like more the thrombosis, like more prominent thrombosis, rather than just vasculitis. So like TMA syndromes, including APLS or cold-associated diseases, like along cryoglobulinemia, there's like cryofibrinogenemia or cold agglutinin disease, that you can have similar pictures. Um, so yeah, those things are what I'm thinking the most right now. How about you, Ravi?
Oh, Maggie, yeah, you just astound me with how you're linking all the different conditions and diagnosis. I think, yeah, cryoglobulinemic vasculitis, I think, is a great thought as well. And I can't help but keep going back to lupus, age range wise, epidemiologically, patient is in that age range. Uh, I'm looking at two potential signals here. One would be cytopenias, right? So here we only have anemia. I don't see thrombocytopenia. I don't see low white cell count. So say there was severe cytopenias, that would get my antennas up for possible lupus. The other thing is lupus is associated as a high likelihood of causing coronary artery disease. And we talked about this chest pain, and the chest pain sitting is better sitting forward and lying back. It's more pericarditis. But I just wonder also, could there be an element of ischemic heart disease here that we have to worry about? And it perfectly fits lupus. Pericarditis perfectly fits lupus as well. But on the EKG, we're just seeing T wave changes. We're not seeing the abnormal ST elevation and PR depression here. So I'm not quite sure. The other thing that nicely links all of these different diagnoses or these different signs and symptoms together is vasculitis. Especially, remember I talked about the vasculitis can impair the vessel distribution or the vessels supplying blood, really important blood to the nerves, and that's how you can get the neuropathy in this case. And then vasculitis can also manifest with the skin, so the dermis, epidermis, getting, or if you would say, the mechanism of the vasculitis immune complex and so on affecting the skin, also affecting the joints. And you tie this all together, vasculitis could be a phenomenon that could explain this. So I think further testing will help. ESR is put in red, is very high. That does indicate inflammation, and each of these diagnoses that we have mentioned is responsible for a great deal amount of inflammation. And the night sweats, the occasional night sweats, rarely, I would say, indicative of an infection, like you mentioned, like subacute bacterial endocarditis could happen. Certain conditions, you could have a sort of quiescent subacute sort of process of endocarditis. But I think further testing will be necessary in this case. I definitely would like to get an ANA and start with that, and then go through the process. We haven't got the chemistry. I think there could be a signal in the kidney as well, like you mentioned. So I'm kind of excited to find out what the next order or labs has in store for us. Back to you, Eugene.
Yeah, I just want to highlight one more differential diagnosis before we go back to Eugene, because I think livedo I think can be associated with both medium vessel vasculitis and small vessel vasculitis. I think livedo is like classically more medium vessel, but then the purpuric lesion is more small vessel. So I think that I just want to highlight one more differential. Actually, Lucas mentioned in the chat that, PAN, and because it's a classic medium vessel vasculitis and can be associated with like deep ulcers or mononeuritis multiplex. So I think that is definitely worth, being high on the differential. I would be, one thing I'm trying to like differentiate between the red deformed purple and this picture is like I feel like red deformed purple would have more pain, like because like there's like even for cryoglobulinemia there are two types, type 1 and type 3. Like type 1 is more like the thrombosis and painful, and type 3 is more like a vasculitis picture. But I don't want to. Maybe I'm just rambling now. But yeah, I wanted to kind of see the progression of this rash as well. But of course, want to catch it early and start treatment early. But yeah, I'm going to pause here and just wanted to just add that differential to the DDX.
Yeah, fantastic. So I'll give us the chemistries. BU Pikeman, Pikeman was normal, 0.5 milligrams per deciliter. Urea was 12 and also normal. And electrolytes were fine, sodium, potassium. Liver function test, we also did that. Total bleeding was normal, AST, LT, albumin were all normal. We also did protein profile, was all remarkable. We did HbA1c, 6.1, the spread diabetic. Did some serologies. These were the initial labs that we sent to HIV hepatitis B, hepatitis C testing were all negative. BDR was negative. Also did a check step was normal. Then we tried to see what was going on with the anemia. So we did reticulocyte count. Was mildly elevated at 3%. Then we did a peripheral blood film, which showed normocytic non-recurrent anemia with no schistocytes, no blasts. LDH was elevated at 320. We did a direct Coombs test, which was positive. Then we did urinalysis as well, just to check. It revealed 3 to 4 red blood cells, trace protein, other things were unremarkable. Then we did urine protein fighting ratio of 0.25 gram per grams. I'll just pause here for you to analyze these ones and then I'll take the last but one aliquot and review the final findings.
Oh, very interesting. So in discovering this journey of anemia, so how did the CBC? Only the blood count was, or the hemoglobin was low. The rest of the panel was normal. And then nothing major in the chemistry. I was suspecting maybe the kidneys could be an alarm for something going on. There's mild hyponatremia, liver enzymes, not really mentioned to be very, very disturbed. But here, what really is interesting is you start off with what's in red is the reticulocyte count being at 3%. So when you start sort of working up anemia, start using the retic count, retic index can be very helpful because then you can kind of see what's going on in the bone marrow. The bone marrow response can really help you to direct, is this a primary bone marrow issue or is this a peripheral process? When the retic count or index, I guess is going to be high, 3% in this case, it's going to indicate the bone marrow is responding or trying to compensate for an external process. What could the external process be in this case? It could be something as simple as losing blood. It could be sequestration somewhere, such as in the long bones, in the retroperitoneal space. And then the other thing could be, could this be destruction? So peripheral destruction, such as autoimmune hemolytic anemia or one of the MAHAs, or physical force trauma, or infectious process, or abnormal architecture of the red blood cell itself, like liptocytosis, spherocytosis, and so on. So the Dreg Coombs here kind of pivots us away from the case of MAHAs and primary red blood cell disorders, more so towards autoimmune hemolytic anemia. So here it'll be crucial to determine if this is a IgG or IgM mediated process. The other cause of this would be something where you get repeated blood transfusions. So this all it will depend on what kind of immunoglobulin is causing this. And if we go back to what we had mentioned earlier, Mengyu, you had mentioned lupus. Lupus is notoriously associated with warm autoimmune hemolytic anemia. Other causes could be malignancies, lymphoma. Sometimes IBD can be associated with it, but this does raise a particular question as to could this be lupus mediated autoimmune hemolytic anemia. On the peripheral smear, we didn't see any schistocytes. And then going by, oh, the haptoglobin is normal. So this is very odd. What do you do in this case? We were anticipating a low haptoglobin in this case for hemolytic anemia. So kind of unusual, unless the testing is not correct. LDH is mildly elevated. Usually with hemolysis, you would um, anticipate a really high LDH. Another signal for hemolysis would be the AST will be out of proportion here. I think we didn't get the AST here. So either this test is a false positive or there is something that is influencing the test and it's not following the usual pattern that you would get with the autoimmune hemolytic anemia. There is anemia, of course. The hemoglobin is low at 6.1. But yeah, I'm a little confused as to what's going on here. I'll send the mic over to Mingyu. I kind of rambled on for a bit, but is there anything you can make sense of this?
Yeah, this is very interesting. Yeah, so the direct Coombs test, yeah, I agree, clarifying whether it's IgG or C3, which would indicate IgM. And I think the haptoglobin being normal is very interesting because I feel like most of the time, if there's a hemolysis, even if it's like autoimmune hemolytic anemia, you would have some low haptoglobin. Although I wonder if it's like a really chronic process and maybe, especially because IHA, autoimmune, I mean, is mostly an extravascular hemolysis that happens in the spleen. So the spleen mononuclear phagocytes would like opsonize these like labeled IgG labeled RBCs and kind of uh, hemolyze them there. So then maybe you don't see much extravascular signals. Um, so I think it's still a possibility that there is some IHA. So yeah, I think that haploglobin like that is interesting. I don't know how common it is you see a normal haploglobin in IHA, but I assume that could be a possibility. And I think at least we ruled out like schistocytes like the TMA systemic like TMA process or MAHA. We ruled out MAHAs basically, but IHA I think is the next thing that's very possible here. I'm also curious about the reticulocyte count because I learned from the website, the Blood Project. I think it's written by Dr. Ayard, William Ayard. Like I used to like be confused of how to interpret reticulocyte. Then I saw his article that basically look at the reticulocytes, absolute reticulocyte count. If it's more than 120, it means the bone marrow is responding appropriately, then producing. So I'm curious, the 3% seems almost a little bit on the lower end if you see how low the hemoglobin is. So I'm curious, maybe the bone marrow is not responding as much as it should be. So then maybe there's some underlying nutritional deficiency as well, like iron deficiency. I think, oh, but however, the MCV being normal, so unless it's like a mixed picture, maybe there's some reticulocytosis and there's some iron deficiency, maybe then you get a normal MCV. But I was expecting the reticulocyte count to be a little bit higher if it's purely a hemolytic anemia. Um,
Yeah, it depends on the units, right? Retic index, if it's greater than 2, would be in comparison. So you calculate, I don't remember the calculation, but yeah, retic count greater than 2 would be indicative of like a good response.
Yeah, I guess it's still
Um,
like a little bit high. Yeah, so I think
yeah.
that maybe like the could still be supportive of a peripheral destruction like IHA process. So yeah, I think adding the autoimmune hemolytic anemia because for that you see uh 50% is just primary on its own, and 50% you can have other systemic immunologic disorders or lymphoproliferative disorders like lupus. I don't see other signs of lymphoproliferative process. I'm just wondering, can we rule out lymphoma or other things? I think next step would be like an ANA and ENA panel for sure. And I think we lost the whiteboard, but also I think some other labs would be helpful in conjunction as uh, we wait for the workup, like other autoimmune workup, including RF, CCP, and like cryoglobulins. Yeah, cold
So
agglutinin disease I considered, but it's sometimes you see some signals of if the comb is C3, then you can think about that. And then sometimes there's um, thrombocytopenia due to clumping, and you can see, but I don't see those here.
Yeah, Mengyu, just to add to that, with the haptoglobin, yeah, you're absolutely right. Yeah, it's not going to have the same effect, or it's not going to be altered like with the intravascular hemolysis. But if you go back to haptoglobin being a acute phase reactant, I just wonder, it's trying to be low with this, so it won't be as low as with the intravascular hemolysis. But with inflammation, and we have a great signal for inflammation, the SED rate is crazy high, right? So 150. So haptoglobin may be normal because of this inflammation and this fight between hemolysis and then also inflammation. So maybe that's why it's like registering as being in a normal range.
Yeah. And Eugene, did you say the next aliquot will review the diagnosis?
Yeah, basically. Yeah.
Okay, so Ravi, maybe we should try to commit to a final diagnosis.
Oh wow. Okay. Yeah, I
Waiting
would need
for
more
other.
testing. We haven't got the rheumatological testing, but
Yeah.
I think yeah, definitely the ANA will shed light if the ANA is the entryway. If it's high, then definitely I would do anti-Smith double-stranded as well. If those are negative, then I would have to pivot to considering vasculitis as a cause here. But I definitely we're sort of occupying this case is occupying the autoimmune space, and definitely I am strongly thinking lupus versus vasculitis.
Yeah, one thing I'm trying to get better is to try to commit to a final diagnosis because sometimes the differential is so rich that it's hard for me to decide which one. But I think in this case, I do lean towards lupus, just given the wide systemic involvement of the potentially pericardium and the IHA, and even though we don't have kidney, but there's enough like different types of organ involved that makes me think about lupus. So yeah,
Yeah, and
yeah.
when what do you call it with lupus? I think yeah, pan was a good thought as well, but I think the medium vessel vasculitis usually won't cause this level of skin involvement that we're seeing here. All right, yeah, back to you, Eugene, for the final D.
Yeah. So the rheumatological labs, we did a and it was positive. Titers of 1 is to 400. Complement levels were low, C3, C4. C3 was 0.55, C4 was 0.08. And then we also did anti double-stranded DNA that was positive. We ruled out the other positive potential causes. So for the positive vasculitis, ANCA was negative. We also did anti-phosphorylated antibodies, they were negative. The multi factor was also negative. Then we repeated the echocardiography, which still showed that we run diastolic dysfunction. Also did some other labs, fighting kinase was normal. And yeah, so we basically can tell from that that the final diagnosis was systemic lupus erythematosus. Yeah.
Wow, man, you another case of lupus. You know, it's funny every time. It's like, is this lupus? And it's interesting that it's you still are unsure about the diagnosis. There are certain patterns and features. And what's interesting, yeah, warm. I have seen this with lupus before, but it's odd. Like the haptoglobin was normal. Like, wait a minute, this doesn't jive, and something peculiar is happening. But yeah, every not every patient is going to read the textbook, and I've never seen the rash on the soles with lupus before, but I think it can happen. So very interesting case. Very well presented, Eugene. A remarkable case and presentation. Thank you for being this case.
Yeah,
Yeah.
thank you so much, Eugene. That's such a great journey, such an interesting case, and seeing the different flavors of lupus. Also, last time when we thought someone had lupus, turned out to be not lupus, turned out to be HIV in in the case that yeah. So I think it's always interesting. I think also seeing how it presented. For example, the IHA here is interesting to how to um, like find that as a supporting evidence of lupus. Yeah, I think just a lot of learning again from you, Eugene. Thank you so much.
Yeah, just to add a little bit, I mean, I like the discussions a lot, especially with the I had that we were considering because this patient had received hemotransfusion. That's something I didn't include in this case, but she had received some hemotransfusion. So when we saw those labs, we thought could it be some delayed hemolytic reaction over there? But uh, my seniors were also thinking that if there's some form of compensation. So just like Dr. Ravi mentioned that maybe because the hemolysis has been ongoing and there's some form of compensation, the hemoglobin will be just either borderline low or normal. So you could still find normal in people still having hemolysis. And so they were more bent on we having the high LDH direct positive consensus to pin on hemolysis. And then I think when I saw this case, I saw this case first before we moved it into inpatient. So she came in to the clinic. I think my thought train, why I love to present this, though is bread and butter, is how much CP solvers try to position us into these schemas. And it's very, very helpful because when you see a patient with a rash, you're wondering, what could this be? Is it? But we have this wonderful schema on the website that all of us can check out, which I used specifically for this case, which asks you whether you start thinking whether it's inflammatory or non-inflammatory. So you need to now find out any symptoms with this patient that can point to an inflammatory cause. And from the get-go, we realized this patient had this fatigue, multiple joint pain. So you can start thinking of something systemic ongoing. So that can point your mind to a possible inflammatory cause of the rash. And then you have to examine the rash properly. So that's what we did. And getting to know that it's non-blanchable, perforate, palpable. We are thinking it's a vessel issue. And just like was fantastically discussed, you want to consider vasculitis. And then we want to consider whether it's possibly immune or it's immune complex. And that's where you do all these labs. And then if these were to have come out negative, there's still a next step. You have to rule out cryoglobulinemia, like was mentioned, although our hepatitis C, which is really the commonest cause. Not the commonest, but the cause of cryoglobulinemia was negative. You also want to go a step further. And then I think at the end of it, or if you're not finding the cause, you biopsy the rash. And if there's a phenotype in the kidney, you can still do biopsy there and then find the cause of this particular problem. So yeah, I've also never seen lupus with rash underneath the soles of the feet. So all the other differentials which came up earlier, syphilis and all of those were also considered within this case. And so very excited to have presented and fantastic discussion.
Yeah, maybe before we give the mic to Krishna, I just wanted to also appreciate Eugene for sharing the picture of the rash because I think it's much easier to recognize a retiform like a livedorsicularis or a petechia purpuric on the white skins. I think for black skin, we need to just open our eyes and be more experienced and seeing all these photos to help us improve our skill in like examining the skin. So really thank you, Eugene, for sharing that. And I really thank you, Simi, for such wonderful describing and highlighting all the important, pertinent positives. And maybe we can give the mic to Krishna.
All right, thank you for that amazing discussion about Dr. Ravi and Dr. Mengyu. That was really awesome, and there was a lot of learning from this session. So to open the session with the first aliquot, Mengyu mentioned that when we see a rash, we should always question like, is it a primary skin disorder or is this a footprint of a systemic disease? And from the two things, like the thinking in terms of the involvement of the skin and the systemic disease, like what evidence do we have for either of those? To look for the skin itself, we have to focus on the nature of the rash. So is it a maculopapular rash? Is it a purpuric rash? Is it a nodular rash? And are there any secondary changes? And we have to keep in mind the ethnicity of the patient, because like in this patient, it was particularly not very easy to describe a rash, especially in African American population. And at the same time, whenever we see certain things like a purpuric rash, we have to think, is it a bleeding problem or is it a vessel problem? And the signs that point to us to a vessel problem would be a non-blanching rash, a palpable purpuric rash, or as in this case, a reticular pattern, which strongly hints at the vessel. And then we have to think about the site of the rash and the distribution. As in this patient, the sole was sort of a unique presentation in terms of the lupus presenting with a skin rash. But we have to think, is it involving the palms? Is it involving the soles? Is it involving in a centripetal fashion or a centrifugal fashion? And then other symptoms associated with the rash itself. So like pain, itching, joint swelling, fever, and other systemic diseases. Coming to like the systemic aspect of the disease, like how do we know whether this is a systemic disease with a rash presentation or a primary skin disorder? We look for things like associated involvement of other organs. So as in this patient, there was joint involvement. And one thing we have to always remember is that immune complexes are something that can readily deposit in both the skin and the joints. And we should also think of like infections that can affect both the skin and the joints at the same time. So like bacterial infections, viral, spirochetal infections, fungal infections. And in this patient, the footprints to a systemic disease that we have were rash, involvement of the joints, and also involvement of the nerves, which was very typical. Whenever we see these, we have to think in terms of vasculitis, autoimmune disease, either in conjunction with vasculitis or vasculitis occurring alone, infection, and then malignancy. Mengyu pointed out a very useful schema to think of like polyneuropathy type symptoms, either typical neuropathy or atypical neuropathy. Typical neuropathy would present with the classic 3S's of symmetric involvement, sensory predominant symptoms, and a slow progression. Whereas an atypical polyneuropathy would present with like a motor predominant symptoms or a rapid progression or asymmetric distribution. And she gave us some very useful mnemonics on how to remember the causes of this. So like AIDP, autoimmune disease, and certain rare conditions like AIP, acute intermittent porphyria. And then we can think of B, which is like B vitamins, and C, which is compression or cauda equina syndrome, and D, which is for like drugs or toxins, particularly like heavy metal toxin. Coming to like the joint involvement, we should always think of like, is it monoarticular or polyarticular or oligoarticular? That will kind of help us further down the diagnosis of what the systemic disease in this patient would be. Whenever we think of vasculitis, we should always think of, is it an immune complex mediated vasculitis? Is it ANCA mediated vasculitis? Because we don't really know what is the underlying pathology of ANCA mediated vasculitis. We should always test for those antibodies. Is it a complement mediated vasculitis, or is it a cryoglobulin mediated vasculitis, as the tests for these things can be very different and like separate. And sometimes we can think of like vasculitic mimics, so like endocarditis, malignancy. In this patient who had a levidoid pattern of involvement, one classic rash that we can, or one classic cause of vasculitis that we can think of is medium vessel vasculitis, like polyarteritis nodosa, which was very classically causes neuropathy and skin involvement and things like that. The only atypical feature here would be this widespread involvement of skin. And when we looked at the labs, we saw that this patient had a predominant anemia. And Dr. Ravi pointed out a very useful trick to divide anemia into either a hypoproliferative or a hyperproliferative state with the reticulocyte index. If it is low, we think of the involvement of marrow. If it is high, we think the marrow is responding well. So it is blood loss, either due to sequestration or destruction. And then Mengyu continued that with saying, like, is the destruction either intracorpuscular, that is happening within the membrane of the red cells itself, or like paroxysmal nocturnal hemoglobinemia, G6PD, PKD deficiency, and things like that, or is it extravascular? And there is a whole host of like extracorpuscular, extravascular causes. So there can be autoimmune hemolytic anemia, there can be MAHA, and one classic thing that we can look for in the peripheral smear for patients, if we are looking to diagnose an extravascular cause, would be schistocytes, which would be very, very specific. Other things we could potentially use are haptoglobin, but it can be tricky because we have to remember that haptoglobin itself is an acute phase reactant. And so if you have the hemolysis going on and inflammation going on at the same time, it can be falsely normal because one tends to kind of negate the effect of the other. And when we see a DCT positive, a direct Coombs test positive, we should always ask, is it a IgG positive or is it C3 positive? Because one can be complement mediated and the other is antibody mediated, and the two have very different differential diagnosis. And finally, for this patient with this widespread systemic symptoms and this prolonged time course of over 3 months of fatigue and other symptoms, we always have to send ANA as a very important diagnostic step. It has a very good sensitivity to pick up autoimmune conditions, and we can rule out autoimmune conditions based on that. Also, as Eugene did here, they sent complement and they sent ANCA antibodies, and in this patient we had ANCA positive with a very strong titer of 1:400, and at the same time the very specific antibody for SLE, which is the anti-double Smith and anti-double-stranded DNA antibody, came back positive. And so we are confident in making the diagnosis of lupus in this patient. And thank you so much for all this discussion and teaching.
Oh, wow, Krisha, that was a lecture on lupus. Amazing delivery of teaching points. Remarkable. It really does prove that academy membership does really take you far. Thank you again, Mengyu. Please join again to co-discuss, and hope everybody else has a wonderful Tuesday afternoon, evening, night. Take care. Bye, everyone. Thank you, Eugene, again. Great case.